move on now to the next speaker. Dr. Savini will talk about papilledema and idiopathic intracranial hypertension.
Okay. I want to talk a little bit about bilateral optic disc elevation, particularly since in the question, in the panel discussion before, there was a bit of a couple of questions about that. When you see someone who has bilateral optic disc elevation, I think there are two steps. The first step is to tell the difference between, does the patient have papilledema, which is an ophthalmic emergency, or does the patient have pseudopapilledema, which is not any sort of an emergency at all? So when you see a patient like this is the sort of the 50th out of 50 patients that you see that you're going through, and as Andy Lee said, you look and you can make a diagnosis immediately, and you look at this and you know you're going to be at the slit lamp with your 60 diopter lens, looking at this for quite some time in order to determine whether or not this is acquired disc elevation bilaterally or whether it's a congenitally anomalous disc. So that's step number one. So papilledema, let's just define a couple of things. To the neuro-ophthalmologist, papilledema means optic disc elevation, which is almost always bilateral, and it's due to increased intracranial pressure. We reserve the term papilledema to this set of circumstances: bilateral disc elevation due to increased intracranial pressure. So if that's papilledema, what is pseudopapilledema? And actually, the best definition I ever heard of pseudopapilledema was when I was a fellow in Miami with Joel Glazer, who said that pseudopapilledema is any condition that the world's worst ophthalmoscopists may confuse with papilledema. So if there's anything out there that's going to make you overdiagnose or underdiagnose papilledema, we need to know what it looks like. So when you're approaching a patient, step one, are there signs of a congenitally anomalous disc present or not? That's how you make the determination. And what are these signs? Well, the optic disc is elevated. That's not the issue. I mean, that is the issue. That's not the diagnosis. That's why you have the problem. But if you look, there's no central cup. All of the vessels seem to come from the middle, and they are in an anomalous branching pattern. There are trifurcation, quadrifurcations, etc., etc. So you see here that there is no cup, and all the vessels come from here, and they just appear to be like too many vessels from that one cup. Also, the retinal nerve fiber layer, this is the same one I showed you before, is clear. And in papilledema, you need to have opacification of the retinal nerve fiber layer. That's what papilledema is. So if you don't see that, then that's not papilledema. And finally, you look for drusen. Sometimes you're lucky and you can see it, or you can do it by ultrasound, by OCT, by CT, or you look for drusen that elevates the disc, but even here you notice that the retinal nerve fiber layer is clear. So this is not papilledema. So if you see signs of a congenitally anomalous disc, no central cup, the vessels come from center, they are anomalous branching patterns of the large vessels, a clear retinal nerve fiber layer, and some other cause that makes it look elevated like drusen or myelinated nerve fibers, that's pseudopapilledema, and no further workup is necessary. What I do in my office is I send the patient for a fundus photograph, and I make a copy for the patient, and I give the patient the copy to take with them. I say, if this ever comes up again, just take this picture out and say, do my optic nerves look any different than they looked in this photograph, which was taken 10 years ago? Step two, if it's not a congenitally anomalous disc or pseudopapilledema, what is the cause of the increased intracranial pressure or papilledema? So you have signs of congenital anomalous discs are not present. So now you want to look for what are the signs that papilledema is present and that the swollen disc that's acquired is due to increased intracranial pressure. And what I would tell you is you need to image a patient. If you see a patient with bilateral swollen optic disc that's acquired, the first thing you do is image the patient. And I do MR instead of CT straight away. I think it's a better test. And the only time I do a CT scan is if for some reason the patient cannot have an MRI scan. If it's normal, and I'm convinced that the patient has papilledema, then I will send the patient for a lumbar puncture. If the MR is abnormal, then I'll send the patient on. And it's abnormal how? Either there's a mass, there's a venous thrombosis, there's hydrocephalus, meningitis, or something else, then that patient gets referred to the appropriate person to take care of that. So this is the schema, and then at the end of the talk we're going to wind up down here, and we'll finish with the talk up down there. However, there are other things that cause bilateral swollen optic discs that are acquired but are not due to increased intracranial pressure. All right? And what are they? This is giant cell arteritis. We saw that before. Here's this pale swollen optic disc with retinal nerve fiber layer infarction as well. And remember I told you, that's giant cell arteritis. This is a patient who has exudates, and this patient's blood pressure was 220 over 130. Was sent in for the diagnosis of papilledema. This is a young man who lost vision in both eyes, first in one eye, first in this eye, then in this eye, and this is a typical fundus pattern of labor, hereditary optic neuropathy. All right, and you don't need to do an MRI scan on that. This is the amiodarone that you saw that Dr. Chavez showed you. And this was, as Dr. Lee showed you before, a patient came out of back surgery and could not see and had bilateral ischemic optic neuropathies. And this is a patient who had bilateral swollen discs and a couple of cells in the vitreous and turned out to have syphilis. So there are other causes of bilateral acquired swollen discs that are not due to increased intracranial pressure, but largely there are other clues, like in this one, the cells in the vitreous, in the hypertensive, the infiltrates, etc. If you really cannot tell if a patient's optic disc elevation is acquired or congenital, I think it's reasonable to do an MRI scan on the patient. You don't want to miss a tumor, and because you think that it really doesn't look like papilledema, but maybe it could be, just go ahead and get the imaging study done, and this way you'll know once and for all. Now, what about pseudotumor cerebri? Pseudotumor cerebri is a disorder, or a series of disorder, of increased intracranial pressure that usually presents with papilledema, but not necessarily so. You can have pseudotumor cerebri without papilledema. It's a well-known entity. And in pseudotumor cerebri, you have papilledema due to increased intracranial pressure. The neuroimaging is normal, and the CSF is normal except for an elevated pressure. So the composition of the CSF is normal. And this is the definition of pseudotumor cerebri. Papilledema due to increased intracranial pressure, normal imaging, and normal spinal fluid except for increased pressure. Now, there are a lot of different names for this. And the neurologist some time ago got hooked on this IIH, idiopathic intracranial hypertension. However, I never liked it because it was clumsy, because there were these pseudotumor syndromes that were not idiopathic, that there were causes that were identified. So you had to say, this is IIH and this is pseudotumor, but then people would get confused. So I like to call it the pseudotumor syndrome and idiopathic pseudotumor. But you can call it anything you want, but you have to make sure the people you're talking to understand whether you're talking about the idiopathic form, or what some people still call IIH, and a pseudotumor syndrome that's associated with a known cause. Now, what are the signs and symptoms of pseudotumor cerebri? Headache is usually, but not invariably, present, and I have been impressed at how some people just have no headaches, and very few of the people that I see have terrible, terrible headaches. The people that I've seen that have the worst headaches are the young kids who are on minocycline, and I think it's because they develop a more rapid rise in their intracranial pressure. They have pulsatile tinnitus, they hear noises, they can have transient visual loss, but it's not like the amaurosis fugax that you heard about before. This transient visual loss lasts a second or two, and it's like the rheostat is turned down in the room. And it usually happens when you change positions from a sitting to a standing position. And it can be in one or both eyes. Now, you do not get visual loss with papilledema unless the papilledema is chronic, and you have now a chronic optic neuropathy, and this looks different than acute papilledema. And then you have all of the signs of an optic neuropathy with color vision loss, visual loss, afferent defect, and typical type visual field defects. The only type of visual field defect you see with acute papilledema is some enlargement of the blind spot. So what are the known causes of papilledema, of pseudotumor cerebri? Well, a whole host of them. Vitamin A, tetracyclines, corticosteroids, and cerebral venous sinus thrombosis is a known cause of this disorder. So if you see someone who has what you think is papilledema, you should do an MRI. And what I do is I routinely order, the same time I'm ordering an MRI, I order an MRV. Because if it turns out that there's no tumor, I'm going to want an MRV anyway, because it is the absolute best way to see if there's cerebral venous sinus thrombosis, and if there is, the treatment's different than if there isn't. If these are normal, if the MR is normal, I send the patient for a lumbar puncture, obviously if there's no mass lesion. And this is a young girl that I saw who had an abduction deficit, an esotropia, and who had rather severe papilledema. And when we did the MRV, you can see that hardly any of her venous sinuses fill. So this is someone that we treated with anticoagulation instead of Diamox, etc., and her papilledema and 6 nerve palsies went away, and her sinuses reconstituted, and the flow was back to normal again. And this whole issue of cerebral venous sinus thrombosis in pseudotumor cerebri is one that you shouldn't forget, because this is the one instance in pseudotumor when you can have stroke and death. You could get venous infarcts in the brain, then it can be a very serious type problem. Diamox, there's no data on this as far as I know, but I don't like to use Diamox in this situation because I'm afraid of hemoconcentrating and propagating the clot. How frequent is this? An article appeared by a couple of my ex-fellows and myself, where we looked at a group of people who came into the office, and we would have diagnosed them as ordinary pseudotumor cerebri. But because we do MRVs on all of them, we found out that 10% of them had cerebral venous sinus thrombosis. So that's about, I think, the correct incidence of people who present with papilledema who have cerebral venous sinus thrombosis. And of our people that we found, there was about 9 out of the 10 people in this group of 100 or so, they all had some underlying serious disease. They had some lupus, some autoimmune disease, something else that was causing them to have this coagulopathy that was unrecognized before we made the diagnosis of cerebral venous sinus thrombosis. So, how do you treat pseudotumor? most of the people who have pseudotumor are overweight. And I think that if you have time, if the optic nerves are in good enough shape, weight loss is the best way to treat this disorder. And if you can get people to lose weight, you can cure this disease. The only diuretic that has been ever shown, as far as I can tell, to lower intracranial pressure is Diamox. But you have to use Diamox in doses of 2, 3, and 4 grams a day. And if there's anybody here as old as I am who used to use Diamox orally for glaucoma, you know that people don't tolerate a gram a day very well, so getting them to 2, 3 grams a day is very difficult. Surgical procedures can be done to protect the optic nerve and protect vision. And the way I approach this is if the patient has no headache, I will send the patient for an optic nerve sheath fenestration. If the patient has headache, I send the patient for a shunt. Because headache still persists after the optic nerve sheath fenestration, and in this way the patient will wind up having 2 procedures. This does not lower intracranial pressure. And if the patient has cerebral venous sinus thrombosis, I use anticoagulation. I hospitalize the patient, heparinize them, and put them on Coumadin, and they're usually on it for about 6 months. So, finally, what's the ophthalmologist's role in this disease? To make sure you don't miss papilledema, because it could be a sign. It's one of the very, very few instances in ophthalmology where if you miss it, the patient may die. Image the patient the same day. As far as I'm concerned, they get MR the same day. If it's negative, they need a spinal tap, and only one. And you notice on my treatment of this, I don't have repeat spinal taps as a treatment for this disease because I don't think it's a way to treat the disease. The single most important test to follow whether your treatment is working sequential visual fields. It's not sequential spinal taps. It's not what the optic nerve looks like. It's sequential visual fields. So if you're a neurologist and you are not equipped to do visual fields in your office, you need to have an ophthalmologist involved, because that's the exact, the only way to follow this. And for the ophthalmologist, think of it as glaucoma of the brain. That's how you follow glaucoma to tell whether or not you need to change your treatment. And if the optic neuropathy progresses, you change your therapy, and you don't want to ever wait until you lose visual acuity to change your therapy, because once the acuity is gone, the chances of getting it back are quite remote. Thank you.
Thank you, Dr.